Hello, I am Dr. Mario Festin, and I'm to give to you today a presentation on updates on contraceptive technology. There are some key facts about family planning or contraception. 214 million women of reproductive age in developing countries who want to avoid pregnancy are not using a modern contraceptive method. This is what we call unmet need. Some methods, like condoms, help prevent the transmission of HIV and other sexually transmitted infections. Family planning or contraception reduces the need for abortion, especially unsafe abortion. Family planning reinforces people's rights to determine the number and spacing of their children. By preventing unintended pregnancy, family planning or contraception thus prevents the deaths of mothers and children. So there would be many benefits from family planning and contraception. Because of what I have mentioned, it secures the well-being and autonomy of women. It supports the health and development of communities, prevents unplanned pregnancies and its complications and risks. It prevents adolescent pregnancy and reduces infant mortality and prevents the transmission of HIV to newborns. It also empowers people and enhances the education, especially of young women. And it slows population growth and thus contributes to the growth of the country. We mentioned earlier unmet need of contraception. What I'm showing are some of the methods that are available, but unmet need refers to those women who are sexually active, not using any form of contraception, and report that they do not want any more children, or at least to delay the next child. This concept of unmet need points that there is a gap between their reproductive intentions and their behavior, what they intend to do and what they're actually doing. This unmet need is especially high among groups such as adolescents, migrant workers or migrants, urban slum dwellers, refugees, and women who have just given birth or have just lost their pregnancies, such as in abortion. The reasons for this unmet need could be there are very limited choices for methods. Access is poor, especially among the populations that I mentioned. There is fear or previous experience with side effects, cultural or religious opposition, poor quality of available services, the bias of the users or the providers, and gender-based barriers. This map shows the pattern of world contraceptive use according to countries. If you could see that the orange and the reddish colored countries are mostly in Africa and some portions of Asia. So these are usually the target countries for programs for family planning. However, we have to see that many areas within some of the countries colored blue also have some population groups which have high unmet need. This is a chart which compares the various effectiveness of family planning methods. As you could see, the ones on the top are those which are more effective and maybe are more long-lasting, and those of the bottom are those which are of very limited efficacy and would thus would not be a first choice in terms of an effective method. So the ones on top, such as the implants, the IUDs, and permanent methods, are very helpful. The middle-tiered methods are also very important because they usually would be used for those who would like to space their pregnancies or probably would be very adverse to some of the hormonal or surgical methods. So we will go through some of the methods and follow this outline. We'll describe the method, state the mechanism of action, its effectiveness, who are the women who are eligible to use it, what are the benefits and side effects, and what are the interventions in case there are side effects. We'll be having two sets. First will be on the oral contraceptives, the injectables, and the implants, while the second part of the lecture will deal with the other methods listed below. Let's start with combined oral contraceptive pills. These always have two hormones, an estrogen or a progestin. The distribution of the hormones may be different across the types of pills within the pack. Monophasic means it's the same one, biphasic means there are two patterns of hormones, and triphasic means three. The most common methods of COCs have low dose, meaning that the estrogen is low, but we still have the high dose estrogen. The pills may come in 21-day packs, when this means that there is a 7-day break between the pills, or 28-day packs in which there are 21 active pills and 7 inactive pills. The main mechanism of action would be to suppress the hormones responsible for ovulation so that the woman does not release the egg. It also helps thicken the cervical mucus so as to block the sperm. In case a woman is already pregnant and has accidentally taken a oral contraceptive pill, it has no effect on the existing pregnancy. COCs are generally safe as much and effective as much as 99%. It can be stopped anytime and thus have a rapid return to fertility. There is no interference with sex in terms of the intimacy, and this is a method which is controlled by the woman. The woman is able to determine whether to take it or not and have other health benefits. However, if you do not follow instructions on how to use it, it may not be as effective. It requires that it be taken daily. If you are at high risk for STIs and HIV, it does not protect you, and you may have side effects and adverse health risks. Some of the side effects are menstrual and non-menstrual. The non-menstrual side effects include nausea, some weight change, dizziness, mild headaches, breast tenderness, and mood changes. And menstrual changes would be breakthrough, light bleeding, and some spotting, or you may lose your period. These effects are usually not experienced by all users. They are not harmful, they are usually mild, may be unpleasant for some, and when you stop the pills, they generally disappear. There are also health benefits. The use of combined oral contraceptives provides protection from ovarian and endometrial cancers. The symptoms of endometriosis are decreased, and you have reduced risks of functional ovarian cysts, ectopic pregnancy, and pelvic inflammatory disease. Menstrual-related benefits include reduction of the premenstrual syndrome, decreased bleeding during menses, and decreased discomfort. There is also some health risk, like some women who are susceptible to blood clots may develop it, especially among those who have additional health factors such as hypertension, diabetes, and smoking. The screening for these existing risk factors is thus important. But if you compare taking oral contraceptive pills with having a pregnancy and all of these risks, the pregnancy presents a higher risk of blood clots than those with just using COCs. This table shows the estimates of venous thromboembolism per 100,000 women years, and you could see that for those who are using low-dose COCs, the risk is 3 to 4 times as compared to young women in the general population not using pills, but as compared to those using pregnancy or you are pregnant, it's a third or fourth less. In terms of heart attacks, if you compare the healthy COC user as compared to the COC user who smokes or has hypertension, the risks are low, and it only it's also affected by the age. But comparing to the groups in this, to the age group with the same risk factors, it is still much lower. So the screening for such factors such as smoking and high blood pressure are very important when a woman is to take combined oral contraceptives. Studies have shown that there is no overall increase in breast cancer risk among women who have ever used COCs, but there's a very slight increase in breast cancer risk in current COC users and those within 10 years of discontinuation. So there would be some intensive screening in this period during current use and within the first 10 years after stopping. One of the biggest problems of women is cervical cancer. There is a small increase in risk of cervical cancer among women who have the human papilloma virus, who use the COCs more than 5 years. This is multifactorial. It may also be to repeated sexual encounters or numerous sexual intercourse. And COC users should generally follow the same cervical screening schedule and recommendations as for other women. In fact, some women who have access to oral contraceptive pills have increased access to cervical screening, cervical cancer screening in some centers. We have the medical eligibility criteria, which describes the various categories of women who can take or initiate oral contraceptive pills. We have the first category in which there are no restrictions and they are listed there. Category 2, there are some restrictions and they are listed there. Category 3 are those who have some increased risks as compared to benefits. But if there is no other method available, the women with these conditions could use them, but with caution. These are the conditions who are category 4, and thus taking oral contraceptive pills, combined oral contraceptive pills, is not recommended. For women living with HIV, generally they have their category 1, and those who are taking ritonavir boosted pills should be cautioned because it's a category 2, but they're still allowed to take oral contraceptive pills. So they can take it safely and using low-dose COCs is appropriate. If there is still additional risk of infection, condom use should be encouraged. When do you start COCs? It's usually in the first 5 days of the cycle. You don't need any backup method. But after the 5th day and you want to start it, you might want to have a backup method. There are certain criteria wherein you have to rule out if a woman is pregnant. We do not usually require a pregnancy test, and if that is not available, you could have some of those conditions listed there. After a miscarriage or an abortion, you could start pills within 7 days and no backup methods. If more than 7 days, use a backup method for a week. When you're switching from a hormonal method, you may start anytime. From switching from a non-hormonal method, you have to do it within 5 days, within the start of the menstrual cycle. But after 5 days, you may use a backup method for 7 days. And if you're using emergency contraceptive pills, you can initiate it the next day, but you have to use a backup method for 7 days. Some of the usual problems of pills are those who may have missed it. If you miss 1 or 2 in a row, or you start a pack 1 or 2 days late, take a pill as soon as possible. Continue to take 1 pill every day, but you don't need any other protection. But if you have missed 3 or 4, you have to start a pill as soon as possible. Continue 1 pill each day and use condoms for the next 7 days. But if these pills were missed in the 3rd week of the cycle, just skip the remainder and just start a new pack. There are many misconceptions with pills. They do not build up in the woman's body. You do not need to get a rest from taking pills. It must be taken every day, whether or not a woman has sex that day, because some women just take it when they have sex. But you have to take it when, even if the woman does not have sex. They do not make women infertile. They do not cause birth defects or multiple births. There is no change in the sexual behavior. They do not collect in the stomach. They become metabolized and they dissolve it each time you take it. And they do not disrupt an existing pregnancy. If there are problems, there are some easy solutions. If there are headaches, reassurance is important. You may want to take painkillers. Nausea and vomiting, you may want to take the pills with food or at bedtime. If there's a weight change, you might want to look at the eating habits and encourage some weight reducing exercise. But if these persist, you might want to use a much lower formulation or to switch to another method. If there's irregular vaginal bleeding, you have to reassure the client. We have to make sure that the pill is taken correctly, and we have to review the instructions for taking pills when you miss something. You might want to see if there are other drugs that are being taken. Sometimes non-steroidal anti-inflammatory drugs are useful. And when a woman is complaining of not having any vaginal bleeding, reassure the woman because no medical treatment is necessary and bleeding would recur after you've stopped taking the pills. Again, if these persist, you might want to use another method or choose a lower formulation. There are some who use extended use pills. They do not follow the usual 3-week pattern of 3 weeks on and 1 week off, but they just continue the pills for 12 consecutive weeks without a break, then have a 1-week break. Thus, they only have vaginal bleeding or menstruation 4 times a year or even none at all. There would be a reduction of side effects, especially during the week without the pills. So this is how it is being taken, and this is a graph of how it is taken. So it's like continuous 4 packs for about 3 to 4 months. Let's go to the next method, the progestin-only injectables. These are DMPA and NET-N. These are administered by deep intramuscular injection or by subcutaneous injection for DMPA. These contain progestin and they're similar to the natural progesterone and are released to the bloodstream slowly. There are 2 methods or 2 formulations. One is DMPA, depomedroxyprogesterone acetate, which is injected every 13 weeks, while the other one, NET-N or ethisterone enanthate, is injected every 8 weeks. They have similar effectiveness and safety characteristics and eligibility criteria. They are safe and highly effective, easy to use. They can be discontinued without the provider's help because you just don't appear for the injection. They can be given outside of the clinics, and it could be used by breastfeeding women. It can be very private because people don't see the puncture marks. They also have non-contraceptive benefits. There is a slight delay to return to fertility, and they also do not protect you from STIs or HIV. This is some of the patterns in the menstrual bleeding of DMPA users. The most common is really amenorrhea or loss of bleeding. Some would have infrequent bleeding, and some would have prolonged or irregular bleeding. Prolonged bleeding is actually less, and with using it more, the symptoms follow that pattern presented there. Other possible side effects would be weight gain. It's only about 1 to 2 kilograms per year. And some less common side effects would be headaches, dizziness, bloating or discomfort, mood changes, changes in sex drive, and some loss of bone density, but these return after you stop taking the injections. 1/3 of users have been found to discontinue in the first year because of the side effects, but we would encourage them to use other methods. In terms of comparing the side effects between the two drugs, generally there is no significant difference in all of those different parameters. And we have to remember that women who receive appropriate counseling are more likely to continue using injectables. How about breast cancer and injectables? There is no risk in current or past users, regardless of age or duration of use. Little research has been done on that end. Other health benefits of DMPA include protection against endometrial cancer, fibroids, they protect against pelvic inflammatory disease and anemia. It reduces sickle cell crisis in women with sickle cell anemia, and it also reduces the symptoms of endometriosis. For NET-N, it helps protect against iron deficiency anemia. Going back to the eligibility as presented through the WHO medical eligibility criteria, these are the women who are in category 1. These are the women who are in category 2. These are the women who are in category 3. And in category 4, current women with current breast cancer should not use the injectables. When do you initiate injectables? As with the other methods, anytime the provider is certain the woman is not pregnant, she could start it, and these are the conditions that have to be met, or you could do a pregnancy test, and it turns out to be negative. It could also be started in the first 7 days of the menstrual cycle with no backup method. If it is after day 7, you have to rule out pregnancy or use a backup method for 7 days. And postpartum, and it's not breastfeeding, you could do it immediately, or breastfeeding at or after 6 weeks. Post-abortion or post-miscarriage, immediately. Switching from an hormonal method immediately if it was used consistently and correctly. If switching from another injectable, you can have the new injectable when the repeat injection should have been, at the schedule it should have been given. No backup method is needed. And if you're using emergency contraceptive pills, you use it at the same time as you take the ECP if you have them already, or within 7 days after the start of the menses, especially if you use ulipristal acetate. Some misconceptions include that when we correct them, the information is that these injectables can stop monthly bleeding, and that is not harmful. It doesn't mean blood is building up within the woman. It is similar to us not having menses, and it is not a sign of pregnancy. It does not disrupt an existing pregnancy, and they do not make the women infertile. These are the action things to do when there is a problem related to use of POIs. If there's irregular bleeding, reassurance is important. Tell them this is common, not harmful. You may want to recommend a 5-day course of NSAIDs like mefenamic acid or the valdecoxibs daily. If there's amenorrhea, reassure the woman because no treatment is necessary. If symptoms persist and are unacceptable, help her choose another method. If there is heavy and prolonged bleeding, such as it is twice as much or twice as longer or longer than 8 days, reassure that this is common, not harmful. Mefenamic acid or valdecoxib may be useful. You may want to prescribe iron tablets and foods rich in iron. You might want to consider that there may be other conditions if heavy bleeding continues or starts after several months, and if bleeding becomes a health threat, or if the woman wants, help her choose another method. Headaches would be managed by painkillers, reassurance. You might want to reevaluate if they are persistent. Abdominal bloating or discomfort, you might want to use local remedies. If there's a change in mood or sex drive, ask about her changes in life that would affect these, including relationship changes, give support, and if there are serious mood changes, refer for special care. If there is weight gain, ask about healthy eating habits and exercise. Aside from the progestin-only injectables, we have the combined injectable contraceptives. There are two formulations available. One is the medroxyprogesterone acetate plus estradiol cypionate, or it is the norethistérone enanthate plus estradiol valerate. They function like pills, COCs. They work by preventing ovulation, and they're very effective, less than one pregnancy per 100 women per month. They do not require daily action. They're private. They could be stopped anytime. This is good for spacing. It may take some time to return to fertility, and it does not protect against sexually transmitted infections. It has less progestins compared to the progestin-only injectables because it has an estrogen. The bleeding, however, is more regular. There are fewer disturbances. However, in some there may be amenorrhea. It requires monthly injections, and you have an allowance of 7 days per month. What are some of the side effects? There are still changes in bleeding patterns, some weight gain, headaches, dizziness, and breast tenderness. It is safe and suitable for nearly all women. However, long-term studies are limited. But generally, the benefits and risks are similar to those of COCs. How do we correct some misconceptions? These monthly injectables can stop monthly bleeding. They're not harmful. They do not build up inside the body. The blood does not build up. Are approved for marketing. They do not make women infertile. They do not cause early menopause. They do not cause birth defects or multiple births. Does not cause itching. Does not change the woman's sexual behavior. A very important group of contraceptives are the progestin-only implants. These are rods filled with progestin that are inserted under the skin. There are different methods which are listed there, 2 rods, 1 rod, 6 rods, and generally it is a long-acting reversible contraceptive. It lasts several years and women can just go on. Sometimes they forget they have it. The mechanism is that it suppresses the hormones responsible for ovulation. It thickens the cervical mucus to block the sperm, and they do not affect on an existing pregnancy. They're very safe and effective, 99.95%. They're easy to use. Fertility returns without delay. Can be used by breastfeeding women. They have other health benefits. They have some side effects, and when you have to remove it, it requires minor surgery. It cannot be initiated or discontinued without the provider's help. And again, there is no protection from STIs or HIV. The usual side effects are related to menstruation. It could be any of these things, from light bleeding or spotting to prolonged bleeding to loss of bleeding altogether. These bleeding changes diminish usually after the first year of use of the implants. This table presents what are the patterns of the 1 or 2 rod implants. As you can see, with time, after 5 years, the bleeding patterns become less with time, maybe except the irregular bleeding. For those who are using Implanon, this is the frequency of the bleeding patterns. The most common is amenorrhea and being infrequent. Aside from the menstrual side effects, some women may experience headaches, abdominal pain, acne, weight gain, weight change, breast tenderness, dizziness, mood changes, or nausea. There are no health risks generally associated with implant use, and with these side effects, the duration with they disappear after discontinuation or with prolonged use. Researchers have found that Jadel or Implanon use have no significant changes in lipid and carbohydrate metabolism, liver function, blood pressure, or blood clotting. There are some complications from use. There might be infections at the insertion site. Usually, these are found within the first 2 months. Maybe at the time of removal, it may be difficult. Generally, this is related to how skilled and how easy it was to insert it in the first place. And there might be some expulsions, but these are generally very rare and take place within the first few months. The other health benefits of implants would mean reduced risk of symptomatic pelvic inflammatory disease, reduced iron deficiency anemia, and risk of ectopic pregnancies. So they're like a reduction by 1/100th of the usual risk. These are the MEC categories of women who can use implants. These are the women in category 1, the women in category 2, and it is important that those who are breastfeeding before 6 weeks postpartum can now use it before postpartum period. These are the women for category 3 and for category 4. So when do you start implant use? So anytime the provider is sure that she is not pregnant. Again, the pregnancy conditions need to be ruled out and the list appears here as well. You could also use a pelvic test, a pregnancy test, pelvic exam, or just wait till the next menses. If it is in the first 7 days of the menstrual cycle, you can insert it. For Implanon, it's within the first 5 days and no backup needed. After those days, you might need a backup method, and those are the conditions for the postpartum period. Post-abortion or miscarriage immediately without a backup. If you're switching from a hormonal method, immediately you could use it if the previous method was consistent and correctly used. And injectable users can have the implants inserted within the re-injection window without any backup. After using ECPs, it could be done within 7 days after the start of the menstrual period. So what do you do if there are bleeding changes? If it's irregular bleeding, you might want to use ibuprofen, or you might want to shift to COCs if there is no relief. If bleeding is heavy, you have to give iron tablets to prevent anemia. If there's amenorrhea, we have to reassure the woman that no treatment is necessary. However, if symptoms persist and are unacceptable, refer her to choose another method. Headaches, reassure, suggest painkillers, and you might need to give pain relievers. Mild abdominal pain, you might want to give pain relievers as well and reassure the woman. If there is breast tenderness, you might use a supportive bra, hot compresses, or analgesics. If there is weight change, ask about healthy eating habits and exercise. If these persist and are unacceptable, counsel her about other methods. If there is pain at the insertion site or removal, check that the bandage or gauze is not too tight, replace it, or control the bleeding with pressure, or control the pain with pressure. You might want to give painkillers. If there's an infection, you have to clean it, give antibiotics. And if there's no improvement, you might want to remove the implants. If there's an abscess, you have to drain it, treat it, give antibiotics, and if there's no improvement, you might want to remove them. Some misconceptions about implants are very similar to the others. Hormones do not remain in a woman's body after the implants are removed. Absence of monthly bleeding because of implants is not harmful, and implants do not make women infertile. They do not move or migrate to other parts of the body or significantly reduce a woman's risk for ectopic pregnancy. Now, it is very important that when the woman comes to a clinic and wants to use an implant, the insertion and removal procedures need to be done, need to be explained. You have to provide the post-insertion instructions. They cannot remain in the body after the effectiveness period. Explain the length of protection and when to return, and describe the reasons to return for follow-up regularly at least every year. Some units or clinics give implants reminder cards. So you may want to look at some of the references that we have, and by the end of 2017, the new edition of the Family Planning Global Handbook for Providers will be available. Thank you, and this ends part 1, and you could have a short break while we shift to part 2.